The eye sees, perceives, looks, understands. But the eye also knows how to smile, laugh, cry. It's by studying the eye, its richness and complexities, that Santen has continued to develop and sell for the past 120 years innovative treatments to preserve this precious organ. In today's world dominated by technology, the eye has never been so essential. At Santen, we are committed every day to improving the quality of a patient's sight, thus improving their quality of life. Thanks to ever more effective solutions for treating ophthalmic conditions, we ensure a brighter future in ophthalmology. Born in Japan, we develop our expertise for the benefit of patients and physicians around the world. Our philosophy, our clear vision, exploring the secrets and mechanisms of nature in order to contribute to people's health. Santen, a clear vision for life.
Increasing IOP is a key risk factor in glaucoma progression. IOP fluctuates over the course of a day, with elevated levels at night. And IOP is still the only modifiable factor in glaucoma treatment. But is just a strong IOP reduction enough? Studies show greater IOP fluctuation may increase visual field progression. Quality-based IOP control may be more effective than just quantity-based reduction. Tafloprost has the power to control IOP through day and night with a greater nighttime IOP reduction. Behold, Tafloprost brings you the power of quality IOP control.
Good evening, everyone. Welcome to the Philippine Glaucoma Society Virtual Roadshow. I'm Kathleen Cabrera. I'll be the moderator for this session. This is the third of 4 lectures tackling some of the basic concepts in glaucoma, which includes perimetry, gonioscopy, medical management, and laser treatment. These topics are essential and relevant to any ophthalmologist, especially to those in training. We hope that the residents take this opportunity to learn not only for the upcoming OPEX, but also for their patients. Tonight, we'll be talking about medical management in glaucoma. But before anything else, we'd like to acknowledge the generosity of our sponsor, Santen Philippines, for supporting this event. For those who won't be able to watch this live, or for those who would like to watch it again, please visit the Philippine Glaucoma Society webinars Facebook page. To get things started, please all welcome the President of the Philippine Glaucoma Society, Dr. Manolet Delfin. Sir?
Sorry. Tonight, I just like to go again. Good evening, everyone. Thank you for joining us tonight. This evening will be the start of a series of third on a series of lectures on basic glaucoma and aim for the general ophthalmologist and the residents and fellows. These lectures were developed by the members of the Philippine Glaucoma Society and are constantly updated. And for the benefit of everyone, these lectures will be uploaded in the PGS YouTube for those who wish to replay or rewatch these lectures. The lectures on perimetry and gonioscopy are already up, and so if you want to rewatch them, please click our YouTube channel. These tonight's lecture will be on medical management, and medical management of glaucoma is both a science and an art. So these will be explained to you by our dear lecturer and PGS and beloved PGS member for today. Once these basic lectures are over, we would like to hold smaller and more intimate discussions with the different ophthalmologists in the different parts of the country. So if you have a diagnostic or medical or treatment dilemma in glaucoma, feel free to reach to us. And if you can form a group or a chapter society, we will be happy to oblige you and arrange a meeting for you. I would like to thank the PGS members and the PGS board for their support in this endeavor. And thank you to Dr. Happy de Guzman for spearheading this project. And thanks to the PGS technical team headed by Dr. Rainier Cavar and Dr. Cesar Perez. And our new members, Dr. Jet Riel and Dr. Paul Gomez. They're new, but we've started them working already. And to a recent fellow graduate, the fellow, glaucoma fellow, Dr. Ruel. Thank you also to Santen Philippines for sponsoring us in the past and the coming webinar. Thank you, and thank you again for joining us, and hope you learned a lot from this one. Thank you.
Thank you, Dr. Delphin. Before we introduce the speaker, let me remind everyone that if you have any questions, you may post them in whichever platform you're watching from. We're currently streaming via the PGS YouTube channel, as well as the PGS Facebook channel. Okay. Also, you may also please answer the feedback forms posted in the Facebook and YouTube. This will also serve as your attendance. Okay, for those who would like to watch the videos again, this is also for the previous videos on perimetry and gonioscopy. You may visit the Philippine Glaucoma Society webinars Facebook page. Just scroll on that page and look for the videos you would like to watch. Okay.
Yes.
Now to introduce our speaker, let me call in Dr. Manolito Reyes, past president of the Philippine Glaucoma Society. Sir?
Okay. Yes. I'm just in time. No? So it is my great privilege to introduce our speaker for this evening's webinar. She's a graduate of the University of the East Roman Society College of Medicine and took her residency in ophthalmology at the Jose Reyes Memorial Medical Center, where she became the chief resident on her last year of training. She chose to subspecialize in glaucoma under under Dr. Manuel Agoto at the Eye Referral Center, after which she became one of our consultant in the glaucoma service at the Jose Reyes Memorial Medical Center. Further on, she obtained her master's degree in molecular biology, molecular medicine at the St. Luke's College of Medicine. Presently, she is the training officer of ophthalmology and ophthalmology residency in Jose Reyes and is the secretary of our Philippine Glaucoma Society. I must say that her excellent and consistent work ethics makes her an asset in any organization that she is a part of. Tonight, I want to present to you, without further ado, Dr. Cynthia Verzosa.
Thank you very much, Dr. Ito, for such a generous introduction. So let's get this show going. I'm sharing my slide. Okay. Good day, colleagues. Tonight, we will discuss the medical management of glaucoma. This is the outline of our talk today. We are all familiar with the definition of glaucoma. This is a group of optic nerve diseases characterized by selective and progressive loss of retinal ganglion cells with corresponding visual field loss. Listed here are the risk factors for glaucoma. So you have advancing age, certain medications such as steroids, previous ocular trauma or surgery, refractive state, family history of glaucoma, systemic disorders such as diabetes, and intraocular pressure, which is the modifiable one among all of these risk factors. We initiate treatment of glaucoma with the aim of preserving sight and maintaining visual abilities throughout the patient's lifetime with minimal effect on his quality of life. We also endeavor to reduce the risk factors of glaucoma. So how do we do that? By first removing or controlling precipitating factors, by lowering the intraocular pressure, by correcting abnormal anatomy, by treating underlying pathology, if this is a secondary glaucoma, and by collaborating with colleagues to manage systemic conditions that may contribute or influence glaucoma. When we talk about IOP reduction, we have to talk about target pressure. This is a pressure range that has been estimated to slow down or even halt disease progression. This target IOP is computed based on the physical exam and diagnostic exams of the patient, along with the estimates of progression rate and the life expectancy of the patient. Hence, it is unique for every individual. The target pressure is not a fixed set of numbers. The range may be adjusted depending on life expectancy and risks of intervention weighed against the risk of visual disability. This slide shows how we determine target IOP. We aim for lower IOPs in patients who have low baseline IOPs, those with advanced glaucoma, those who are fast progressors, and for young patients. Conversely, target IOPs need not be too low for patients who have higher baseline IOPs, early stages of glaucoma, slow progression of the disease, or shorter life expectancy. For example, IOP targets for glaucoma patients with high risk for visual loss would be at least a 40% reduction from baseline. For moderate risk glaucoma patients, we target a minimum of 30% reduction. Glaucoma suspects with moderate risk for visual loss should be monitored closely for change over time. The choice and timing of treatment will depend on the patient's risk and preference. Should treatment be considered, target IOPs should be at least 20% lower from baseline. And since primary glaucomas typically involve both eyes, please do monitor carefully both eyes, especially when the patient initially presents with unilateral glaucoma. Glaucoma suspects with low risk for visual loss may be monitored. Treatment may only be considered when the benefit clearly outweighs the risk. Now let's do a quick review of the Goldman equation. As you can see here, the IOP is determined by the rate of aqueous formation or aqueous inflow, the rate of aqueous outflow, and the episcleral venous pressure. Notice that lower IOPs may be achieved by either decreasing inflow or increasing outflow. Please keep this in mind as we continue our discussion. When we consider initiation of treatment, we first consider giving eye drops that lower the IOP. Listed here are the different drug classes of anti-glaucoma medications. You have alpha-1 antagonists, alpha-2 agonists, alpha-1 beta antagonists, beta blockers, carbonic anhydrase inhibitors, cholinergics, hyperosmotics, prostaglandin analogs, and Rho kinase inhibitors. Drugs that lower IOP by decreasing aqueous production are the alpha-2 agonists, alpha-1 beta antagonists, beta blockers, and carbonic anhydrase inhibitors. Drugs that increase aqueous outflow are the alpha-1 antagonist, alpha-2 agonist, alpha-1 beta antagonist, cholinergics, prostaglandin analogs, and the Rho kinase inhibitors. Drugs that decrease vitreous volume are the hyperosmotics. Now, going back to the Goldman equation, here you can see where each of the anti-glaucoma medication exerts its effect that will result in IOP decrease. Now we will discuss each drug class. First, the prostaglandin analogs, or the PGAs. These drugs lower IOP by increasing uveous scleral outflow. It's now recognized as a first-line treatment. And based on studies, PGAs may lower IOP by as much as 35% from baseline. PGAs currently in the market are bimatoprost, latanoprost, tafluprost, travoprost, uniprostone, and latanoprostene bunod. This drug class also boasts of a convenient once-daily dosing. However, patients on PGAs may experience periorbitopathy. They may present with upper lid ptosis, deepening of the upper lid sulcus, involution of dermatochalasis, periorbital fat atrophy, mild enophthalmos, inferior scleral show, increased prominence of lid vessels, tight eyelids, and conjunctival hyperemia, along with thickening of the lashes. Systemic adverse effects are unlikely, although possible. Prostaglandin analogs are contraindicated in patients with uveitis, previous herpetic eye disease, completely closed angles, a ruptured PC, and cystoid macular edema. Now let's discuss beta blockers. These drugs lower IOP by decreasing aqueous humor production. It has gradually lost its status as a first-line agent, although in patients who have closed angles or those who have contraindications to PGA use or find the PGAs too costly, it remains as a first line. Beta blockers are known to decrease IOP by as much as 25% from baseline. Examples are timolol, levobunolol, petaxolol, cartiolol, and metipranolol. Dosing is typically twice daily. Known local adverse effects of beta blockers include stinging, burning, tearing, itchiness, and hyperemia. Systemic adverse effects may be as mild as hair loss and can be as severe as hypotension and bronchospasm. Tachyphylaxis is also observed in patients on beta blockers. Beta blockers, therefore, may not be prescribed to patients with heart blocks, airway diseases, and congestive heart failure. The next drug class is alpha-2 agonist. They lower IOP by as much as 25% from baseline by decreasing aqueous production. Now, brimonidine, which claims to have neuroprotective benefits, has the additional ability to increase uveous scleral outflow, while clonidine and apaclonidine claim to reduce episcleral venous pressure. These drugs are usually given as a second or third line. Examples include brimonidine, apaclonidine, and clonidine, all of which are selective alpha-2 adrenergic agonists, while you have epinephrine and dipivefrine, which are non-selective alpha-2 agonists. Dosing is twice or thrice daily. Common adverse effects to alpha-2 agonists are allergy, burning, stinging sensation, blurring of vision, foreign body sensation, itching, hyperemia, all relating to allergy, basically. Alpha-2 agonists may also cause CNS depression, mouth dryness, headache, fatigue, and drowsiness, even bradycardia, hypotension, and hypothermia, and apnea. Therefore, we don't give alpha-2 agonists to patients who are younger than 7 years of age because they are known to trigger apnea in this age group. And we also don't give them to patients on antidepressant therapy using monoamine oxidase inhibitors. The next drug class are the carbonic anhydrase inhibitors. These drugs lower the IOP by decreasing aqueous production. And like alpha-2 agonists, we give the CAIs a second or third line drug. We expect IOP to decrease by 20% from baseline for the topical preparation and by as much as 40% from baseline for the oral preparation. Examples of CAIs include brinzolamide and dorzolamide, both in topical preparation, and acetazolamide in tablet form. Dosing can range from 2 to 4 times daily. Patients on topical CAIs may experience the following adverse effects. You can have stinging and burning sensation, punctate keratopathy, blepharoconjunctivitis, and the most troublesome of which is the corneal endothelial cell decompensation. Some patients even report bitter taste. Now, using the oral preparation, some patients may experience fatigue, anorexia, gastrointestinal upset, paresthesia, all attributed to hypokalemia. Patients occasionally develop kidney stones with prolonged oral CAI use, and rarely, some patients may develop blood dyscrasia or even Stevens-Johnson syndrome. Because of these adverse effects, we don't give topical CAIs to patients with compromised corneal endothelium. And since all CAIs are sulfonamide derivatives, they are contraindicated in patients with known allergy to sulfonamide. Similarly, oral CAIs are contraindicated in patients with history of renal impairment, metabolic or respiratory acidosis, hypokalemia, and known allergy to sulfonamide. Patients may also experience choroidal detachment and transient myopia. The next drug class is the cholinergic. These drugs lower IOP by increasing trabecular outflow through ciliary muscle contraction. As much as 25% decrease in IOP from baseline is seen in the eyes on cholinergics. Decreased angle crowding and a forward shift of the iris lens diaphragm occurs with cholinergic use. Examples of cholinergics include pilocarpine, ecothiopate iodide, and acetylcholine chloride. Dosing is 3 to 4 times daily. Uncommon adverse effects of cholinergic eye drops include cataract formation, brow aches, myopic shift, retinal detachment, and aggravation of pupillary block. Because of the systemic absorption, additional adverse effects may include salivation, lacrimation, urinary frequency, gastrointestinal symptoms, bradycardia, and hypotension. Cholinergics are not given to patients with uveitis because it may activate latent inflammation. And we don't use cholinergics on patients with neovascular glaucoma because the constriction of the iris and ciliary muscles may cause pain without the benefit of IOP reduction. Now, since cholinergics move the iris lens diaphragm forward, we don't give this to patients with lens-induced glaucoma and malignant glaucoma. Also, cholinergics are contraindicated in aphakic patients and those with history of retinal detachment because of the possibility of inducing retinal detachment. Another drug class is the hyperesmotic. which lower the IOP by as much as 30% by decreasing vitreous volume. Examples of hyperosmotics include mannitol and glycerol and isosorbide. These drugs are usually given as stat doses to break a glaucoma attack. Patients on hyperosmotics may experience symptoms relating to the rapid increase in intravascular volume. Diuresis may also lead to electrolyte imbalance. Hence, monitoring of vital signs must be done when administering these drugs. We don't give hyperosmotic to patients with heart or renal failure, or those with pulmonary congestion. Hypertensive patients may still be given hyperosmotics with caution. The newer additions to the glaucoma medications are the Rho kinase inhibitors, or ROCK inhibitors. These drugs increase aqueous outflow through relaxation of the trabecular meshwork. Patients on ROCK inhibitors experience a 20% drop from baseline IOP. Examples of ROCK inhibitors are ripasudil and netarsudil. These are used at twice daily dosing. Patients on ROCK inhibitors have been shown to develop hyperemia and lacrimation. And most notable of the adverse effects is corneal verticillata, which are whorl-shaped opacities within the basal corneal epithelium. Presently, no contraindications to ROCK inhibitors have been identified. Now we talk about alpha-1 antagonists. This drug works by increasing aqueous outflow, and as much as 20% reduction of IOP has been reported. In this drug class is bunazocine, which is administered twice daily. Ocular adverse effects of alpha-1 antagonists include conjunctival hyperemia, foreign body sensation, and ptosis. Systemic effects may include significant reduction in the blood pressure and even headaches. However, no contraindications have been identified. And another drug class is the alpha-1 beta antagonist. It lowers IOP by reducing aqueous formation through its beta blocking action and increase the uveoscleral outflow through its alpha blocking action. IOP is expected to decrease by as much as 20%. Ipradilol is an example from this drug class and is applied twice daily. The adverse effects and contraindications are similar to that of beta blockers. To improve patient compliance, some pharmaceutical companies came up with fixed drug combination preparations. These include PGA with beta blocker or PGA with ROCK inhibitor. Or you can have beta blocker with alpha-2 agonist or a CAI or a cholinergic. Sometimes it's also an alpha-2 agonist with CAI. Yes. And then IOP drop may range from 25% to 35% from baseline. Now, here you can see how the different drug classes rank according to their ability to lower IOP. So notice that the highest ability would go with the systemic medications like your hyperosmotics and your oral CAIs, and down the line would be your topical medications. In this next slide, you'll see the systemic effects, how these drugs have the ranking of these drugs in terms of their systemic effects. So since oral medications will circulate all over the body, we expect the systemic effects to be higher in such drugs. So I have hyperosmotics and oral CAIs at the top of the list. And in terms of local side effects, on the top would be your PGAs and your ROCK inhibitors. Now, when you have decided to start the patient on medical therapy, you have to consider the following principles. Okay, first, choice of medication. Our choice will be greatly influenced by the drug's ability to lower IOP and to keep it low. Also, please consider the safety profile of the drug. Choose a drug with the least number and severity of adverse events as possible. And dosing should be the most convenient for the patient. And ideally, it should be affordable since glaucoma entails lifetime treatment. The next principle is to start low and start slow. We start the drug at its minimal frequency and increase the dose depending on the response of the patient. This principle is not to be used when dealing with patients with alarmingly high IOPs or with advanced stage of glaucoma. One-eye therapeutic trials may be tried in patients who have glaucoma in both eyes, but of different severity. You may start treatment in the worst eye, then reassess response after 2 to 4 weeks. During this waiting period, we ask the patient for any side effects. If the target IOP is achieved and the patient is happy with this medicine, then we may apply the same drug to the other eye. Again, this principle may not be used when This principle may be tried when there's no relative urgency in controlling the IOP on the patient. So what do we do when there's inadequate IOP drop with our initial drug? We first check if the initial drug was effective, meaning the expected percentage drop in the IOP was reached, but we did not get to our target IOP. So if the initial drug was effective, but the target IOP was not reached, then we add a second drug from a different class. But if the initial drug was not effective, meaning we did not achieve the expected percentage drop in the IOP, then you may consider switching to another drug from the same class or from a different class. Next principle is maximizing the likelihood of patient adherence. The value of patient education cannot be overemphasized. We need the patient's buy-in when you discuss treatment because his cooperation will be needed for a successful long-term treatment. Therefore, we need to come up with the least complex regimen, which means possibly using fixed combination preparations. Also, ensure that the treatment will cause the least disruption in the patient's lifestyle. You may help them set up reminders using their phone-based alarms. Oftentimes, we may need to teach our patient and their companion how to properly apply the drops. Remember the double dots technique. The first dot is don't open the eyes. So this will allow the absorption of the drug when they keep their eyes closed after instillation of the drop. The second dot is digital occlusion of the tear duct. You may instruct the patient or companion regarding the technique and ask them for a return demonstration to check if they have understood your instruction. Please ensure that there's a 5-minute gap between drops. And when available, provide some printed educational materials or refer them to a website regarding glaucoma. Remember too that as we add medications to the patient's regimen, the efficacy is not necessarily additive. Patients already on oral CAIs may not experience the additional benefit when using topical CAIs. Pilocarpine usually has additive effect when used with beta blockers and alpha-2 agonists, but not with PGAs. Also, consider augmenting your treatment plan using lasers, such as trabeculoplasty. Sometimes we may have to go straight to surgery instead of trying out the topical anti-glaucoma medication, depending on the patient's condition. Here's an algorithm from the Asia-Pacific Glaucoma Society Guidelines of 2016. This shows us how to go about our treatment plan. We start with our first line, which is usually a PGA, and then we check if we had reached the target IOP. If we have, then we just monitor the patient. If we haven't reached the target IOP, then we assess if the PGA was effective or not effective. If the IOP dropped by 30% and we fail to reach our target IOP, then we add a second line drug. So this could be a PGA from another PGA, or it could be from another drug class. If the PGA was ineffective, we may consider switching to another drug class. When we reassess, we keep doing this until we reach our target IOP. For those instances when we encounter a patient with acute elevation of IOP, we may need to give multiple medications right away. Occasionally, we may have to administer hyperosmotics too in the hope of achieving a drastic reduction in IOP. Here are the usual rescue medications we use, along with their peak effects. This will guide us when to best assess the response of the eye to our treatment. So in summary, when we decide to start patients on medical treatment, we need to tailor the regimen to the patient's needs. We need to be familiar with all possible treatment options and be knowledgeable how to combine these options for the patient's maximum benefit. We need to be well-versed with the drugs available in the market, their indications, contraindications, and adverse effects. Effective treatment is best achieved when the patient understands his condition and his role in the care of his eyes. Lastly, we treat the patient and not the IOP. Thank you very much for your kind attention.
Thank you, Dr. Verzosa, for that excellent discussion. It was great that you mentioned some of the new glaucoma medications. I think one of the main points from this lecture is the importance of individualized treatment, especially now in this difficult time. Now, for the audience, you may submit your questions through whichever platform you're watching from. Also, I would like to remind everyone to please fill out the feedback forms posted in the chat boxes. This will also serve as your attendance. Now we have the first question from Dr. Cesar Perez Jr. Are the generic PGAs as effective as the branded ones?
Good question. Actually, I don't think we've had any good studies comparing the generic ones to the with the branded ones. Okay, so but in my practice, it seems that they do work. However, because perhaps of the preservatives that is used in the generic ones, the patients complain more often about sting, and probably because of the preservatives. But at least for my practice, it seems to be like that the IOP lowering seems to be comparable. But that's just based on my experience. I don't recall seeing any papers regarding that yet. Maybe that's a good study.
Okay, thank you, Dr. We have another question from Dr. Cesar Perez Jr. again. What are the most appropriate glaucoma medications for kids? How about for pregnant patients?
Okay. Kids usually, that's kind of difficult, especially when you're dealing with congenital glaucoma. We give the acetazolamide. Of course, we compute that by weight. That's why it's very important that you have a pharmacy can help you prepare these paper tabs for such patients. Well, that's what we give. At least in Jose Reyes, we give the acetazolamide. Occasionally, if they're bigger, we put them on selective beta blockers. But we instruct the parents to do punctal occlusion. Also, for pregnant women, the only drug among all of these that's safe for pregnant women is brimonidine. So if you encounter a pregnant patient with uncontrolled glaucoma, it's a very difficult treatment, because you'll have to think about the baby and you'll have to think about the mom. But if the patient, the pregnant patient is already beyond maybe on the second trimester, I think you can probably go for the other medications aside from the brimonidine, of course, but you'll have to discuss all the possible effects on the unborn child. So it's always a coordination between the patient and the doctor. Okay, you'll have to explain meticulously every possible side effect that the baby can have. Okay, in the hope of saving the mother's eyes. It's a tough choice actually for the mom. Okay, and also a difficult time for the doctor because you pity, of course, the mom, and the mom, of course, is careful about the pregnancy too. So there, I hope that answers the question. For kids, yes, we can try the other drugs when they're a little older. Of course, we hold off the brimonidine because they can cause apnea, but we usually resort to the cetazolamide computed according to their weight. Then usually when it's childhood glaucoma, they're surgical in nature. So you use the acetazolamide while preparing them for surgery. Thank you.
Okay, Dr. Thank you. Another question from Dr. Happy. As a glaucoma specialist, what are the common glaucoma medication mistakes that you have seen in patients referred to you?
Oh, okay. The usual problem, okay, the glaucoma patients are usually elderly ones. So they have difficulty applying the medication. So these are the patients who live alone or who live with an elderly spouse. So if they don't have younger people to help them out, the problem is they fail to aim properly. So the drops don't usually land in their eyes. So that's one, they don't put it properly, or if they do, they put in too much. But that's not putting properly. So they either miss their eyes or they put too much of the drug. And then also they can mix up their drugs, their drops, because sometimes the bottles, especially the generic ones, they can kind of look the same. So you'll have to tell them to carefully label each one. If the letterings are too small, you'll have to ask them to put special labels, maybe a red color to mark timolol, example, or a blue color to mark something else. So it will have to be color coded. Also, they can miss their drops. So it would be good to have something like a reminder on the ref, maybe, and they can tick off if they have already applied their medication. So these are the common things that I see in my patients. Thank you.
Thank you, Dr. for those practical tips. We have another question. Do you start with non-preserved medication in patients for better compliance? Because anti-glaumeds cause dry eye and punctate keratitis. When do you start using lubricants in patients with anti-glaucoma medications?
Thank you. For naive treatment eyes, it is okay. I think for me, I start with the preserved ones, okay? Because especially if I'm not, I usually start with the preserved ones. Okay, they're slightly cheaper, and the cost actually will matter at first to the patient. For a lot of my patients, at least, they're senior citizens. They're relying on their pension, so they have limited budget. So we end up using the preserved ones, and we end up using the generic ones. But as we see more and more reactions to the drugs because of the drug itself, so maybe you can have hyperemia because you're on prostaglandin, and then the age-related dryness that they also may already have. I try to switch them slowly to the non-preserved eye drops so that they can feel better, especially when they start complaining that their dryness seems to get worse. But of course, you can choose to go straight to non-preserved eye drops if the patient has very bad dry eyes already. If these patients are young, because you don't want their conjunctiva to be so inflamed because of the preservatives of the drugs. Also, patients who have existing allergies already, because you don't want to be aggravating it. That's the time I start with the non-preserved preparations. Thank you.
Okay, thank you, Dr. We have more questions coming in. This one is from Dr. Patricia Colliantes. Are PGAs as effective to use in primary angle closure glaucoma compared to its use in primary open angle glaucoma?
Okay, theoretically, the PGAs will not work on angle closure because the drug will have to access the 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 sclera to get to the uvuscular area. Now, but sometimes we've seen patients who still improve with PGAs, those who have been given by their previous doctors the PGAs, and we see that their angles are closed. And I think it may have something to do with the closure too, because sometimes the angle closure may not be the iris exactly covering the meshwork itself, but more like it's still some gap. So maybe through the iris, through the crypts in the iris or some areas, thin areas in the iris, the drug can penetrate and enter the meshwork. Now, but theoretically, the PGAs should not work, or at least theoretically, it will not work that well in angle closure. But you know, there are exceptions to the rule, and I'm sure you've seen your share of patients who have improved IOPs even when their angles are closed and they are on PGAs. Thank you.
Okay, thank you, Doctora. This one is from Dr. Manolet Delfin. Do you do diurnal monitoring to check if the IOP is controlled throughout the day with the eye drops?
Sometimes, depending on what kind of glaucoma I may be dealing with. But if this is normal tension, I probably would do it. But otherwise, especially if you have a very busy practice, say you spend 2 hours in one clinic and another 2 hours in another place, it's very difficult to do a diurnal. So instead, I ask them to come back at different times. So let's say I ask to see them, let's say in the morning, and then the next checkup, I see them in the afternoon or midday, and have a glimpse of their IOPs. Because in my mind, I'm thinking of the typical pattern of IOPs in the typical circadian pattern. So you have the highest IOP at the early morning, and then it's a downward trend, and then you have the lowest IOP in the evening. So I have an idea of what's happening. So I just want a snapshot. So I don't really do a lot of diurnals. Thank you.
Okay, thank you, Doctora. We have another question. There are some patients who will start using their anti-glaucoma medications when they're about to see their doctor. How do you think we can monitor that patients are applying their medications regularly?
Oh, this is what I do. I ask them to bring their drops always. So, and then I secretly put little marks on their bottles. The patients don't know that. So I borrow it, and then I kind of smudge it a little bit. So I know if this is the same bottle that they're bringing next time, because I look for that mark. Also, I ask them politely, and most times they admit when they forget, at least most times. But sometimes, you have to catch them. You catch them in their lie? But that's how I do. That's how I check if they are really compliant. And then I also ask how many bottles they have bought over the past months. And if they say, just if let's say I saw them 3 months ago and they come back and they report to me that they had just bought one refill, then I know they're probably missing some drops. Thank you.
Okay, thank you, Doctora. We have another question. This one is from Dr. Ashley Buko. In advanced cases where patients are not amenable to surgery yet and are on oral CAIs, how long do you keep them on oral CAIs?
Thank you. Well, for as long as possible. But the longest I've kept a patient was on CAI was 3 months, but because we couldn't get a CP clearance for him. And while we were on CAIs, I was monitoring his kidney function. So, but of course, the patient's already aware that the prolonged use of oral CAIs is maybe detrimental to his health, may bring in additional health problems, but that's the trade-off. So as long as it's clear with your patient what you intend to do, it's clear to them why you're doing this, why you're doing some things, then I think the patient will understand if they start developing symptoms, or if if they start developing symptoms because of the adverse effects of the medicine. Thank you.
Okay, this one is from Dr. Delphine again. After starting initial medications, when do you ask your patient to follow up?
If there's really no big rush, like if this is not advanced glaucoma that needs to be operated on right away, I ask to see them after 2 weeks. 2 weeks of treatment, 2 weeks of using their eye drops, as long as there's no big rush to check their IOP. Thank you.
Okay, thank you, Doctora. I have one question for you, Doctora. In your practice and given our current situation, is there a change with the way you manage your glaucoma patients? For example, is there a shift from your usual medications or conservative treatment towards a more aggressive treatment now, or is it the other way around, or is there no change?
The change that I had to do was to do the checkup faster. Since most of my patients are elderly, they tend to talk a lot about their grandchildren, about their hobbies. So I had to cut that short. But the actual examination, I just have to do it a lot faster. But in terms of treatment, it's still the same because I tell them what is at stake. And most of them will agree that their eyes are precious. So they're willing to come back for checkup. Of course, we make allowances if they're sick, if they can't go to the hospital, or there's a lockdown, there's a quarantine issued in their area. We understand that, but they realize that they do have to come back, and we cannot do telemedicine with glaucoma at least. It's very, very difficult. They know that we have to check their IOP, that we know that we have to monitor regularly, and so they cooperate. And that's why it's very important to talk to your patient. That will mean longer chair time. That will mean you will have to spend so much time with them explaining everything and maybe repeating yourself on the next checkup when they have a different companion. But that's how it is. And we have to be patient because you remember these are elderly patients. They probably will forget. So you'll have to write down. Okay. But there's really no big change, except that there's less chit chat during checkups. Thank you.
Thank you, Dr. So this last question is for the benefit of our residents who are watching. Of course, we do not just treat the IOP. We also have to coordinate the IOP with the visual field changes. So how often do you need to monitor visual field changes among patients on medical therapy?
Initially, I asked for visual fields every 6 months for the first 2 years of the patient, because I need to have a good baseline. So I ask that kind of frequently. But once the patient seems to be stable, meaning the visual field is not deteriorating, and the IOP seems to be in a good level, then we do it at least once a year.
Hi, thank you, Dr.
Thank you.
We have one more question from YouTube, Dr. This is from Miko Fernandez. What would be the maximum number and types of topical IOP lowering medications you would use in combination for a POWAG patient who may not be amenable to surgery?
Okay, topical. Okay, since you have the fixed drug combination, you can probably have just 2 bottles for your patient. So that's PGA and beta blocker, and then you have a CAI and an alpha 2 agonist. That will be the combination that you can have if your patient's not available to surgery or you're buying time.
Thank you, Dr. One last question. What do you think will the role of medical therapy be as we move into this new normal? Do you think it's going to take a back seat, or do you think it will be the preferred approach by most ophthalmologists?
Oh, that depends on the situation of the area and the patient too. Most patients will prefer eye drops. Well, most of them. I don't think anybody wants to be operated on. I don't want to be operated on myself unless it's really needed. So I think the medicine will stay, and if we have better delivery system, maybe that will work too. Maybe surgery will probably take a back seat because people don't have a lot of income now. Okay, especially if they're depending on their pensions, on depending on the allowances from their children. It's a difficult time during this pandemic. So I think the medicines will have to be the mainstay for now. Of course, but you'll have to do a little math too. Yeah, you look at the economic side of it. If it's going to be cheaper in the long run, if you do the surgery now, because you cut off the monthly expenses of say 5,000 a month for this patient, then maybe the surgery will be a better option. But I think, at least in the patients that I see, they still prefer the medicines. Thank you.
Okay. There are no remaining questions for our speakers, so let me again thank Dr. Verzosa for a wonderful lecture on the medical management in glaucoma. Thank you also everyone who submitted their questions. So at this point, let me call in the District Sales Manager of Santen Philippines Incorporated, Mr. Nairo Ubaldo, for a few words.
Thank you, Dr. Cabrera. In behalf of Santen Philippines, we would like to thank Dr. Manuel Delfin, Dr. Happy de Guzman, all PGS members, and technical team for partnering with us for this PGS Roadshow. Also, our esteemed speaker, Dr. Cynthia Verzosa, who have provided an interesting discussion in glaucoma medical management. We at Santen ensure that we provide quality of ophthalmic solutions that provides patients power to control their glaucoma all day long. This is in alignment to our new corporate slogan, which is Imagine Happiness, that describes both our aspiration as doctors and as specialized ophthalmic company in not only slowing down glaucoma progression, but also in improving a patient experience, thereby achieving happiness for all individuals by focusing on vision. Associated to what our speaker said, the goal is for the patient to meet target IOP, minimize adverse events, and tailor management to patient needs. And definitely, or lastly, is to ensure what makes patient happy. Again, thank you and see you on the next roadshow.
Thank you, Santen Philippines, for your continued support. We look forward to working with you again. Now, before we end this webinar, let's hear from the Vice President of the Philippine Glaucoma Society, Dr. Hannah Pia de Guzman. Dora?
Thank you, Kaka. Good evening, everyone. One of the missions of the Philippine Glaucoma Society is to educate our fellow ophthalmologists. Thus, we have organized this series of webinars on basic glaucoma topics. Tonight, we have concluded the third of our 4 webinars. I'm very grateful to everyone who has made this series of webinars possible, especially tonight's webinar, starting, of course, with our speaker, Dr. Cynthia Verzosa, Santen, our sponsor, and everyone who has participated, especially the PGS technical team. But of course, our mission would be for nothing if we had no one to teach. So thank you so much to our audience for spending your precious time with us this evening. Good night, and thank you again to everyone.
Thank you, Dr. Happy. We hope to see everyone on Tuesday, September 29th, for the last of the Glaucoma Roadshow series. Lastly, we'd like to thank the IT team composed of newly accepted members of the PGS, Drs. Jet Rayel and Paul Gomez, and the PAO side person in charge, Ruel Villanueva. Thank you, everyone, for tuning in, and have a great night.